Good morning, everyone. My name is Tina Lopez. I am the clinical educator for AQTS Home Health, and today we're going to go over a gastrostomy tube virtual refresher. I'm going to go over what a gastrostomy tube is. We'll talk a little bit about its components and how we can determine its sizing. We'll also go over daily care, possible complications, and how do we attend to them, how to administer feedings and medications, and then how to replace the G-tube. First things first, what is a gastrostomy? So let's start here. It's a surgical opening so that they create a stoma through the skin and the stomach. It's a very common procedure. It can be done via percutaneous and endoscopic gastrostomy. So you'll hear PEG tube, you'll hear G-tube, gastrostomy tube. And once they switch over to a low profile, then you'll hear G button. Patient may need one for a variety of reasons. So there's failure to thrive, there's issues present at birth, such as, problems of the mouth, the esophagus, the stomach, any sucking or swallowing disorders, developmental delays, prematurity, things of that nature. We want to use it to give formula, liquid medication. We can vent the patient's abdomen if they're distended. We can provide additional nutrients if they still need more versus what they're getting by mouth. If they're not growing well enough, then we'll give them that. Some patients, you'll see that they'll have it for a little while, and then others you'll see that they'll have it for pretty much the rest of their lives. And it all just depends on their medical condition. Okay, so let's cover some basic components of the G-tube. The balloon is here, so that's the silicone retention balloon. It holds it in place. You can use sterile or distilled water. You don't want to fill it with air because it's going to migrate out of the balloon and the G-tube can dislodge. Sterile or distilled water is what's best. We want to confirm the volume that's in the balloon, and that's once a week or as ordered on your plan of care. There was a nurse and she was checking the balloon, and as she pulled back to assess how much distilled water was in there, it looked pink. Well, this patient was on an antibiotic. And so the nurse previous, or whatever nurse it was, maybe even the parent not knowing, gave the medication through the balloon port. So the patient never received the antibiotic. Do not use the balloon port. I put a little symbol there. So where it says BAL, that's the balloon port. This in particular is a Mickey button, the one that I'm pointing to up top. Patients can usually get that after about 6 to 8 weeks after they have surgery. And then that is what their low profile, meaning it's flush to the skin. So they have that, and they'll have the balloon port here. The G-tube that I'm pointing at down at the bottom is the one that you'll usually see that's placed with surgery, and they'll have a disc here, centimeter markings across, and you would then document what that centimeter marking is here. There's also the balloon port on this side, the feeding port here, and then the medication port here. And all of those can be covered with the port because where the balloon is, and here where it says BAL, that is where you would then inflate the balloon. All right, so if they have a G button, they are going to need an extension tubing to administer any feedings or medications. Otherwise, you can't access it. So if you look at this versus the previous one that I showed you, the G button, it's only this by itself. And so you do have to attach it. We have to wash the extension set after every feeding with warm soapy water. Prevents the drying and the buildup of bacteria, but they are also disposable and should be replaced every few weeks. If you can't clean it out, just throw it out. So some patients, they receive several feedings during the day and it's not on the pump. So we would do a bolus feeding. So there is an extension tubing here. You would just hook up like a 60 cc, 60 ml syringe, and you can give it by gravity. So the higher you hold it, the faster it's going to go. So a nice steady pace is what we would want to do there. Here's our button, right? And so when you open the button, it's right there. We would just connect where the line is on here. We're going to match it up and we're going to turn it. And there it is. So it has a clamp, so you can clamp it. And if a patient has a lot of distension, then, you may want to just prime this before you give them all this air. And then you would just hold it to gravity. So this is what it looks like, G-tube with the bolus. If you're not doing the bolus, Then there's just your usual connection for the Mickey. So it has medication port, feeding port, connector. Same thing, you would just connect it. When you line up the lines on the G-tube and the tubing, you do want to push down and do about a quarter turn, but you don't want to forcefully keep turning it because it'll break the inside of it and then it'll create the leakage too. All G-tubes are sized by the width of the tube, which is measured using the French scale. And you know what? I need to share my screen again. It's tricky sharing it and unsharing it. Sorry. Okay, so using the French scale, so across the diameter of the tube, so you can see here, the diameter in French size for that G-tube that's listed is a 16 French. And then the stoma length is actually what is between the balloon and the bottom of the G button. That section there is the stoma length. The bottom of the base of the G-tube should rest just above the skin surface. So you don't want it to be too tight or too loose. If it's too tight, then you'll see redness and irritation underneath. If it's too loose, you're gonna see leakage. So if you think about a dime and you turn it on its side, that's about how much space should be there. Okay, so about 1/8 of an inch above the skin. Patients with G-tubes are at risk for hospital readmissions due to reinfections related to the gastrostomy tube, mechanical complications, and the need for the G-tube replacement. So really learning about proper G-tube care can help prevent hospitalizations and complications for our patients and hopefully keep them home and free of infection. So with our assessment, we want to develop a habit of inspecting the skin around the tube, so around the stoma, before and after every use. Assess and monitor the site for signs of infection. So overall, does the patient have a fever? At the site, is there redness? Is there swelling? Is there any odd looking drainage, cloudy, or is there any hardening around the site? The skin around should be clean and dry. Moisture does promote bacterial growth. We want to monitor for any abnormalities. Stoma care, we want to make sure that our parents or caregivers are educated on how to provide that. So review your plan of care and see what it is that the provider would like for you to clean it with. Most of the time, warm soapy water with their bath time is fine, or just some sterile water. We want to do that at least twice a day. I know that it's very common for us to use the 2x2 gauze. I've seen some people even stack it and do 2 2x2 gauze. I do not recommend that. The more that's underneath, it's pulling the balloon up and it can cause irritation. And again, bacteria loves warmth, bacteria loves moisture. Those are places where it loves to grow. So if there's no drainage, there really is no need for a dressing. If you do use one, then just make sure and change it as soon as it becomes soiled. You really don't want to allow it to sit there a long time. So with our G button care, it's good to use cotton tip applicators. You can use your sterile water. You only want to dip it in there once. Okay, so you dip it in your sterile water and you will then clean around the G-tube and toss the cotton tip applicator, grab another, dip the new one into the sterile water, clean around the G-tube. Okay, so you can get underneath too, like underneath the little edges there. And use just a gauze and just pat it dry. Okay, of course, we're performing our hand hygiene. We are wearing gloves. It was a story that I had heard about a nurse that did not wear gloves with her G-tube care because she was very comfortable with the patient. She had been there a long time. And what ended up happening is she did her G-tube care and she didn't wash her hands afterwards. She rubbed her eye, and a little bit later she had to go to the hospital because the gastric secretions were still on her hands, and she then rubbed her eye and got a bad infection in her eye. So do not take that lightly. I know that you can get comfortable, but let's not do that, okay? Rotation of the button is important just so that it doesn't adhere to the stoma. So we do want to do that 360 degrees every shift and as needed. We don't want to put tape on the patient's skin. If they have a GJ tube or a suture G tube, then we don't want to rotate it because it can become dislodged. Always have a replacement Gtube available to prevent hospitalization, a physician visit, and maybe even a surgery. So make sure that the caregiver is knowledgeable on how to change or replace the G button. So we're going to go over a couple of complications here. With bleeding, it may happen if there's granulation tissue buildup or irritation from the Gtube. So with any bleeding, you would always call the GI doctor or the PCP if there's any bleeding or a significant change in status. For infections, we can help, again, prevent infection by doing a proper assessment and knowing what to report to the physician, doing our daily NPR and cleaning, and keeping that area dry. If we were to notice an infection, same thing, notify the provider. If we notice that the G-tube becomes clogged or sluggish when you're administering medications or feedings, then you can flush it. Look at your plan of care to see what the appropriate amount is for that patient. But if it continues to be clogged and if you have an extra one in the home, just replace it. Prevent clogging by flushing it routinely, dissolving your medications, and then learning about incompatibility between medications and enteral feedings. Granulation tissue. It is a pinkish, reddish, fleshy tissue around the G button site. There might be drainage, bleeding, sometimes a foul smell that's associated with it. And it is the result of the G-tube moving and the body trying to heal around it. So that is why it does that. Look at your MAR and find out if you have any PRN meds or ointments that can be used. They normally will have a regimen that they're using to try to lessen that, but we also want to make sure we let the provider know if they haven't been notified yet. Sometimes some patients might need that silver nitrate. Leakage, we know that a little bit of leakage is normal, a small amount, if it's tan or clear, that's okay, but if it's a large amount, so just making sure that the first thing that we do if we see leakage is check the balloon. So we're going to see how much is ordered in the plan of care. If it's 5 mLs, did you pull back 5? If you didn't, and if you pulled back 4, you're going to reinstill a full 5 amount, brand new 5, and then later on you're going to reassess and see if it went back down. If it did, there's probably a leak and we should change that. Aspiration. Patients with a G-tube are at higher risk. So aspiration, just a quick overview, it's the entry of gastrointestinal secretions, oropharyngeal secretions, solids, or fluids in the airway. Aspiration pneumonia is the cause of respiratory morbidity and sometimes mortality in children. So different risk factors would include the patient being supine during the feeding, have impaired level of consciousness, if they have reflux, any neurological deficits, dependence on the ventilator, or if they have bolus or continuous feedings. So things we want to do to prevent aspiration, we want to make sure we're positioning the patient appropriately 30 minutes to an hour after the feeding, preferably greater than 30 degrees. We want to routinely verify the placement of the tube as well. Okay, so also check your plan of care. Can you do an air bolus? You wouldn't do this with the G-tube, but some do want residual checks. So if it is on the plan of care and ordered by the doctor, then okay. Clinical assessment of the tolerance of the feeding. So if there's abdominal distension, any discomfort, or any excessive residual trends. And then of course, we want to make sure that we're managing the GERD. Okay, so G-tube replacement, you got this. So I did put a timer here because normally about 20 minutes is like the max that we have to, switch that out. G-tubes routine placements are recommended every 4 to 6 months, but we know that malfunction and dislodgement, that can happen. So in an emergency, do not panic. If it does become dislodged, these are the things you're going to do. Okay, so first thing, you're going to check the balloon. If it doesn't leak, then clean it with soap and water and you can put it back in. If the balloon doesn't work, use your replacement button. Okay, you want to make sure that there's one in the home. If you have nothing to put in the stoma, if there is not one in the home, then replace it with the old button, tape it down, just put it back in. And that will at least keep the stoma open until you can seek medical attention. And if you can't get anything back into the stoma, of course, we're going to want to go to the ER immediately. Routine changes in the home, we want to make sure the providers, the caregivers are educated and that they can independently change the tube, because we know that nursing is not always available if a nurse calls in or they're low on their staffing for the week. We want to make sure that we empower our parents and caregivers to know how to do this, okay? Oh, and these are the things I already said. All right. Okay. Administration of feedings and meds. Hand hygiene, I know it's a broken record. I know that everybody talks about it and it's like, I've already been told and told, I know. But it is one of our national patient safety goals for a reason. So I do encourage you to look at what the proper hand hygiene technique is. I also have videos that I looked for online. So I have links for that if you're curious. But just making sure we're always washing our hands thoroughly, sing the happy birthday song twice, just before we touch any feeding tube, food, or medication. We don't want to get comfortable and not utilize those things. We put our patient at risk and we put ourselves at risk too. Okay, so this just goes a little bit through how we're going to tackle this. So always confirming our placement. We talked a little bit about that. Confirmation of the feeding formula, medication being given. We're going to administer it as ordered. And then we're going to document how the patient tolerated it as well. So what was administered, how much was given, over what time, and what route as well. Feral bags, I haven't seen super commonly in the home, but they are nice to consider if we have a patient that has excess gas or pressure, which is otherwise known as gastric distension or bloating. So if we notice that that is a recurring thing for the patient and they're really struggling with it, we can always ask the provider and see if they'll want to order a feral bag. So I thought that it was still neat to go over so that you understand the setup of it. So the feral bag, it can be aligned with the feeding. Okay, so at that height, we want it to be above the patient, above the pump. So then there's the Y connection. So the Y connection connects to the feeding tubing and then the feral bag. So that needs to be below the patient, below their belly. And then that's it. And then we want to just make sure we're priming it. If you have any questions or your patient does end up with the feral bag, we can run through how we prime it. But it is very, very helpful for patients that have a lot of that distension. Some last minute tips that I jotted down here. Flushing the Gtube with water, whatever is ordered on the plan of care, but really before and after any tube feeding, before and after any medications. We want to make sure that our medications are given separately. So don't mix them up, especially if you have not looked at the compatibility. Flushing it at least once every 24 hours. And then if they are on a continuous feeding, then you want to flush it and the extension set tubing at least 3 times a day. For medications, we'll touch on a couple of things as well. So you want to give liquid medications directly into the medication port. And then for pills, just again, check with the doctor or the pharmacist before you crush them. Same thing with capsules before you open them. And you can, of course, mix them up if it's approved. Always give 1 med at a time. I did say that. And then formula temperature does matter. So we want it to be warm. We don't want it to be hot ever. Okay, but a good warm to room temperature is okay. And the last thing is just to always remember our 5 patient rights. So right patient, right medication, which in this case, it's a feeding, but it's still equally as applicable. Okay, so the right formula, the right route, the right dose, the right time, and then additionally, the right documentation and the right patient response. Alrighty, and that is all I have. I will be posting this on our Can Time training and letting you all know how you can access this. If you feel that you need some hands-on, I know it's a little tricky doing it on Zoom. Personally, it's new for me too. But if you feel that you need some hands-on training, whether it's the Gtube or the vent or the trach, if you're looking to go from a low-tech to a high-tech patient, I am more than happy to help you with education in the office, okay? Alrighty, have a great day.